I do have a handful, and certainly our patient, Miss J, that we started with doesn't fit into this, but I have a handful of patients who are older, they have dementia, maybe we have them on metformin just to try to, like, we're really trying to just keep them less than 8 or just make it so they're not having complications of hyperglycemia. In those cases, sometimes I'm almost forced to like use a medicine that I normally wouldn't use, like a baby dose of glipizide or something like that, or which always feels wrong, but sometimes it just seems to like stabilize people. And because you have these people that are 8.5 or 9%, and you don't want to give them an injection. So I don't know if you have a trick for those kind of cases.
I know exactly what you're talking about. And at that point, you do have to make sure adherence is well understood by everyone, the patient and whoever's helping the patient. I can't tell you how many incredibly diligent families tell me that, yes, the pill box is full and she's doing it right. And then they call me and they say, you would not believe this, but she's been taking X. This actually just happened last week. Like, she's been taking glimepiride this whole time. And I had actually stopped it because I did switch her to insulin. I did. I had to. She was polyuric and losing weight. This happens at the end of the natural history of type 2. But I didn't want her on both. And anyway, the point being is, it's hard when people have cognitive impairment. Non-adherence or screwing up the meds is so incredibly common that we just want to make sure we understand that they are taking what we're prescribing. So Matt, I do try to use DPP-4 inhibitors in those patients. Try might not be the right word. I use them. I use them because they can sometimes help to move an A1C from 9 to in the 8 range, and maybe protect somebody from more aggressive, consistent hyperglycemia. They're safe, obviously, in advancing kidney disease. They're they're not potent, as you know.
Right.
What I often do when you have a patient like you're describing, and the DPP-4 inhibitor is just not going to do anything, I do use low dose glimepiride. And the patient I just described, case in point, I did try that first because I knew insulin was going to change her life. It was going to change her family's life.
Yeah. Someone has to go over and inject them sometimes if they're not living with family. Yeah.
And it puts her at risk.
Down that road.
Yep.